Example this morning, but I'm actually here to introduce Dr. Chinnery, whose background and studies are about that long. So I'm going to give you some of them because he's got quite an extensive background. He received his training in neuroscience and general medicine at the University of Newcastle in the UK. And he's focused on molecular basis of minor diseases. Well, he further was into clinical trials and neurology and genetics in Newcastle. He was 11 years as a professor at Newcastle. And after that, he was professor at the University of Cambridge. He's been very busy and quite extensive. He's department head of the Clinical Neuroscience and the Medical Research Council, Mitochondrial Biology Unit. He leads clinical translational research group for development, new treatments, clinical trials with pharmaceutical. His research is primarily in identification of mitochondrial and nuclear gene defects for mitochondrial diseases. He's dissecting out the downstream disease mechanics. Then he's studying the molecular and cellular basis of mitochondrial DNA. His lab studies are the mechanisms of mitochondrial DNAs in patients and model systems, and his goal is understanding why certain cell types are vulnerable to mitochondrial disorders. So I'll introduce you to Dr. Chinnery, and you have the floor, sir.
Thank you, Gary. You make me feel kind of old. I've been doing this amazingly for 25 years. I first started as a junior neurologist in 1995 with Douglas Turnbull in Newcastle. And really from a very early stage, I was interested in how hearing can be affected in mitochondrial diseases. And what I've put together are some slides with great help from my colleague Peter Kullar, who's a proper hearing doctor. He's an otolaryngologist in Cambridge who largely constructed the presentation. And I will speak to them from a neurological perspective. But before I do, this is the first time I've ever given a talk to a dog. I've got 3 dogs at home. This is the first time. And rather like being at home, the dog's pointing in the wrong direction. So I feel completely at home before we start. What's the dog's name?
Sasha.
Sasha. Okay. Well, let's hope we can perk up Sasha by the end of this session. So, listen, it's a small group, this, and I'd much prefer it if you interrupted me as we're going along, because the purpose here is for me to try and pass on some of my understanding and some of the bits I don't understand to help you appreciate where we are in trying to work out what's going wrong in mitochondrial diseases and therefore work out how we can best support and treat patients and families with mitochondrial diseases, particularly here today with regard to the hearing side of things. So I really want you to interrupt me with questions if you don't hear me, if you don't understand what I'm saying. Let's take our time. I've got a deck of, 20 slides. We've got an hour. We can go at a good pace so that you are connected to me right the way through. And we've got microphones if needs be. So what I'm going to try and do is explain to you something about the causes of hearing loss in patients with mitochondrial diseases. I'm going to talk to you about some of the treatment options. I'm going to talk a bit about current research, and we'll come across some of the outstanding questions that we as researchers need to try and address to improve your lifestyle, your quality of life from the hearing perspective. So where should we begin? Well, we should begin with what we're talking about. We're talking about hearing, and this is the bit of the hearing that you're all familiar with. It's a picture of the ear, And doctors like to call things special names, and this slide is labelled with the special names that divide up bits of the ear that you can see on the side of your head. These names are not important, but the shape of this is very important because it essentially catches sound waves and channels them into the bit inside the skull which senses the sound and leads to hearing. So all of this weird shape channels the sound waves into this hole here called the external auditory canal, which is how the sound gets into the skull and gets picked up. Now let's look at this in a slightly different way. So here's the ear on the outside, and here is my skull being chopped in this direction here. So it's a slice through the head. This is what it looks like. So this is the outside, and here's the ear. And this yellow here and brown are bones and fat around your skull. And this is the mechanism that allows us to hear sounds. And it's important to talk about this because it gives you an understanding of how mitochondria affect this. So what happens is the sound comes in this direction, is channeled by this outer ear into this external auditory canal, and it's picked up by this group of bones. They are actually the smallest bones in the body. There are 3 of them. Here's an expanded version of them here, and they connect to the eardrum, which is at the end of this canal, external auditory canal, and like some gears, they sense the sound as it hits the eardrum, and they increase the size of the vibration through these 3 bones, and they connect to this part here called the inner ear, which senses the sound. Let's go back one, sorry. So if you look down your ear with one of the otoscopes, which is basically a lens and a small telescope, and you look down the outside of your ear, this is what you see. So it's blown up to a huge size, so this might be maybe 1/4 of an inch across, and it's the eardrum.
I think we might.
Do you want me to hold this?
Need a little bit.
Do you want me to hold it?
Sure.
It doesn't seem working, does it? Okay.
I guess because we're talking about hearing impairment, we might have a little bit of hearing impairment. And I'm talking about myself here.
Okay, my apologies. So this is the eardrum, and you can see the tiny bones connected to the eardrum here. And this is what first picks up the sound. But the thing that really does the work are these hairs or hair cells that are deep inside the ear. And these are the things that pick up the vibration in the air, the sound, and convert it into a message that the brain can understand. These are tiny. You can't see these with your eye. They need a special microscope so that you can see them, which is how you can see them here, and they're deep inside your ear. And this is how they work. This is a cartoon. These are the hairs on the hair cells. And what happens is the sound wave comes in and it pushes the hair cells, and this triggers an impulse in the nerve which travels to the brain, and it's how you hear. That's how the hearing mechanism works. Hearing needs energy. It needs energy because these cells use energy to work properly. This is a mitochondrion, something that you're all very familiar with. And because hearing needs energy, hearing needs mitochondria. And so if your mitochondria are not working properly, you can't hear properly. So let's go back to our picture of the ear. There are 2 types of hearing loss. One is called conductive hearing loss. And conductive hearing loss is basically when there's a block to this system here in the external auditory canal, or this mechanism with the bones in what's called the middle ear. And this is a very common problem, but not in people with mitochondrial problems. So you may have heard children getting something called glue ear. Glue ear happens when you have a block to this system, and you basically get a collection of fluid around these bones, and it muffles the sound coming from the outside and causes hearing problems in kids. And people treat that by putting a little hole in the eardrum to let the fluid out. The hole is kept open by something called a grommet. That's what we call it in the UK anyway. And it's a very common problem, but it's not a problem that particularly affects people with mitochondrial conditions. So for the ear, nose and throat doctor, the otolaryngologist, seeing people with conductive hearing loss is the most common thing they see. But people with mitochondrial disorders, the hearing is affected in a different way. What happens is a problem deeper in the ear, called the inner ear here, in the sensing mechanism. And the sensing mechanism with those hair cells sits in this little curly part of the ear called the cochlear. It's tiny, it's only about 1/4 of an inch across, and you've got one on each side. And that's the thing that contains the hair cells that converts the sound into the nerve impulse that goes down this nerve here into the brain. And when there's a problem with this part of the hearing system, we call it sensory neural hearing loss. And this is the type of hearing problem that patients with mitochondrial disorders get. And unfortunately, it's not as simple as putting a little hole in the eardrum to drain the fluid, which is what we do in the kids. Correcting this is much more challenging because it involves nerves which are difficult to repair.
Excuse me.
Yeah.
So, is vertigo at all related to this?
Good question. So it is related to this because this inner ear, it's a perfectly timed question though actually. It's almost like a plant. So,
I'll take my $50 now.
yeah, you can get that from the back. So this is the bit that's important for hearing. There's this other bit to the inner ear called the semicircular canals, and these little tubes, there are 3 of them, and they're orientated in different directions. And the semicircular canals are how we pick up the position of our head in space. So when I turn that way, the fluid moves in the semicircular canals, and it's sensed in this part here using something a bit like the hair cells. And it's how your body knows where your head is in space and how it's turning. Now, vertigo is a word that doctors use to describe the sense of movement when no movement's present. So I'm stood still and I feel the world spinning around, but my head's not moving. And one cause of vertigo is because of damage to this system, which normally picks up normal movement. In other words, it's kind of saying your head's moving when it actually isn't. And you can see it's next door. It's right next door, within a few millimeters of the hearing apparatus. And in fact, there's a similar biology to these 2 parts of the hearing system. And so you're absolutely right that if you get damage to this bit because the mitochondria aren't working properly, you can get damage to this bit. I have to say there are other more common causes of vertigo. But I think your question's very sensible because the link between balance and hearing is very close. And we know from studies in patients and families that people who have hearing problems with mitochondrial disorders, often have problems with balance. And one of those is vertigo. So, absolutely right. So mitochondria are most important for this form of sensory neural hearing loss. And that's very helpful to understand, but it also presents us with a bit of a challenge. So this is a typical picture of all the different problems that people with mitochondrial conditions can get. Now, everyone doesn't have all these problems, and most people just have a few of them. But if you run a clinic like I do, you see all these problems in different people as they come through the door. Now, you can't read all this, I realise that. The purpose of the slide is to illustrate the fact that the mitochondrial disorder can affect lots of different parts of the body. But at the very, very top here is sensory neural hearing loss. So it's common in people with mitochondrial problems. It's kind of near the top of the list, along with all these other neurological and non-neurological problems that patients can get. So, how can this present to doctors? Well, there are some people with mitochondrial disease who only have hearing problems, nothing else. It's the only feature of their mitochondrial disorder. And the truth is they often get missed because people don't think that when you have hearing problems on their own that it could be a mitochondrial disorder. But we know that is the case. However, lots of people with mitochondrial hearing loss also have other problems. It might be muscle weakness, it might be diabetes, it might be fatigue. And so we can see the hearing loss on its own or with other symptoms. And in fact, when we've looked at this across our clinics, we find that about a third of, the important point is, a third of people with mitochondrial disorders have normal hearing for their age, because of course, as we all get older, we lose our hearing. It's part of normal aging. What that tells us is that 2/3 of our patients have problems with their hearing. So it's a big deal, this hearing problems in mitochondrial disorders. It's a big part of it. And I think it often gets overlooked because people go to see their physician and their physician sees that they can't walk, or they've got droopy eyelids, or there are other problems with their muscles, and they forget to ask about the hearing problems because it doesn't seem to be important. But if you think about it as a doctor and you pick it up, there are some things we can do that can really transform people's lives. So I think one of the messages I always try and get across when I'm talking to doctors about mitochondrial disease is the importance of asking the question, how's the hearing? Or even doing a hearing test just to make sure, because we often forget. And the important thing is that the hearing problem could be quite mild or it could be quite severe. Now, if it's severe, it's obvious. People go to their doctor and say, hey doc, I can't hear. I'm having difficulty when I'm in a crowded room. I'm having difficulty when I'm around the dinner table and all the kids are speaking. But the hearing problem could be quite mild. And it might only be an issue when you're out there in a room full of all people talking away there. You just can't connect to anyone. And so you might not recognise it as a problem because it gradually crept up on you over many years, maybe decades. But only by doing the tests can you show there's a hearing problem and give treatment, which can have a big difference to your quality of life. So we as doctors need to be thinking about this more. So how does this work? Well, as I've explained to you, the nerves that are involved in detecting and transmitting the sound into the brain require energy. The hair cells in this part called the cochlear, which is where the sensing happens, something called the stria vascularis, which basically makes that part of the ear healthy, needs energy, and also the function of the nerves themselves, the auditory nerve, the hearing nerve that goes into the brain, and the brain itself also need energy. And what we see in people with mitochondrial disorders is that some or all of these different parts don't work properly. And it's important to try and work out which one, if we can, because they may require different kinds of treatment to try and allow people to operate normally in their home environment. One of the things that's very important to remember, of course, is that you can damage your hearing. Any of us can damage our hearing by exposing ourselves to extremely loud noises. And some people are particularly sensitive to certain medicines that can make their hearing worse. And people with mitochondrial disorders in particular, one specific genetic cause, are very sensitive to a kind of antibiotic that's often used on the intensive care unit. I'm with you, two seconds. On the intensive care unit. And it's very important that that's avoided. Okay, because it can make the hearing loss. It's called, there are a group of antibiotics called aminoglycosides, and you get them in injection form. So you only get them if you're really sick. But people with mitochondrial problems, we should avoid those if we can. So, questions?
Yeah.
Yes. No, go for it.
Is there any correlation to some of the various process of hearing loss, mitochondrial disorders with tinnitus? I mean, is that
Yeah.
one of the symptoms or one of the problems?
So tinnitus for everyone is ringing in the ears. And in fact, any cause of hearing loss can cause tinnitus. So yes, that could be the symptom. So tinnitus happens, it's thought to happen because there's a loss of feedback between the sensing mechanism. It's almost as if the brain's filling in the gaps. It's not hearing, so it senses a ringing sound to fill in the gaps. So any cause of hearing loss can cause tinnitus. So absolutely, tinnitus is one of the symptoms.
So I lost my hearing in my 20s,
Yeah.
and it was after a treatment with doxycycline for Lyme disease,
Yeah.
and then was later diagnosed with maternally inherited deafness and diabetes, and then that, now is MELAS. So I wonder if there's is there any studies on doxycycline?
Yeah, interesting. So it's related antibiotics. So I'm not aware that people have directly shown a link between doxycycline itself and mitochondrial hearing loss. But you're right to ask the question. These are really difficult things to do because these studies are really difficult things to do because mitochondrial conditions are rare. So to be sure that there's a causal link between the doxycycline and the hearing loss, really you need to have a big group of people, some of which you had the treatment, some of which you didn't, and show there's a difference between the two. That's really challenging for a condition that only affects 1 in 8,000 people. So you may be right, but I have no evidence to prove it. Good question.
Doxycycline, tetracycline, they're all the same.
Related.
Are they related to like gram-positive bacteria?
Yeah.
Gram-negative?
Yeah, and so if you really want to get into the detail, it all makes sense because if you want to get into the detail, your mitochondria, if you go back billions of years, are thought to have come into our cells in the body from being primitive bacteria. This is 2.5 billion years ago. And so treatments that we develop that can tackle bacteria might also affect mitochondria because they're kind of related. And in fact, these aminoglycosides specifically affect the way mitochondria make proteins inside themselves. That's why they're good antibiotics, because they stop bacteria making proteins inside themselves. So it makes sense that there's some kind of overlap here.
My question is whether or not any studies that you know have linked high CFF pressure or CSF leaks to the hearing loss, because just in my local Mito community, those of us that have either suspected or probable Ehlers-Danlos have recently also dealt with leaks in CSF fluid or intracranial hypertension, also known as pseudotumor cerebri, and we also have hearing loss issues. I myself have a shunt now because of it. The hearing losses preceded all the diagnoses of the leaks and stuff, so I was just wondering because they're so closely related to the sensory nerve.
Yeah, so raised pressure inside the fluid inside the brain can cause hearing loss. I don't know a direct link between that and mitochondria myself, so I think that might be a completely separate issue. Would be my view.
Other than antibiotics, are there any other specific environmental effects you're aware of that disproportionately affect Mito patients?
Yeah, so there's a lot written about this, isn't there? And if you look in the medical literature, there are many reports linking one thing or another. So, for example, a condition I know a great deal about, Leber's hereditary optic neuropathy. It's a mitochondrial disorder that affects the eye. And there are lots of stories of people being exposed to different insults, psychological stress, physical trauma, so a head injury, certain kind of toxins like smoke from burning tyres. All of this has been written about. And it's very, very difficult to know whether those links that people are describing are just chance and that people were in that situation going to lose their sight anyway, or whether or not there's a real causal link between the two. You can be really cautious if you want to and avoid all of these things that have been written about, but basically you'd end up living your life in a bubble in your house, you'd never go out. We're going to be exposed to some of these things. And in the end, as a doctor, my aim is to improve your patient's quality of life. And so I have to balance up how strong is the link versus what's the effect of getting people to avoid these things. So my personal view is, unless there's a really well-established link, just let's try and avoid the burden of trying to avoid that thing, because we don't really know. And I think for most of these reported links, we don't really know for sure whether there's something environmental that would trigger mitochondrial disorders in general. The best example is, or the worst example if you like, is the aminoglycosides and people with maternally inherited deafness, hearing loss. And there's another one which is in patients that have mitochondrial disorder caused by Pol-G or polymerase gamma. There's a particular anti-epilepsy treatment called sodium valproate, which we know is toxic in those patients. Apart from that, it's kind of educated guesswork, really. They're the two strongest links we know about.
So you keep saying aminoglycosides, and is gentamicin in that category?
So it isn't. Gentamicin is one of those. So gentamicin is one of those.
All right. The second thing is that hearing loss that can be caused by gentamicin, can it be temporary or is it permanent?
So I think what people report is that initially things get worse and sometimes they get a bit better, but literally within weeks or months of stopping the treatment. But usually it's permanent.
And how soon after you have the gentamicin does the hearing loss happen?
So people often are really sick when they get the gentamicin.
Yes.
And so they're not kind of aware of what's going on. So but I would say it probably days to weeks, not longer than that. So if you had gentamicin 5 years ago and your hearing's going down now, very unlikely to be related.
Okay, because this was 6 months after.
Yeah, I think that's... Because of course the problem is you don't really know when the hearing loss began. You know when it causes symptoms, but you don't know when it began. And so, yeah, interesting question. I would be, if it was 6 months, I would be, I think it's plausible that it was related to the gentamicin.
It's plausible.
Plausible, I would say, yeah. Yeah. Okay. Good. So how do we look at hearing? How do doctors measure hearing? Well, routine way is to do something called a pure tone audiogram. And to do this, you usually go into a little booth, soundproof room, and put on some headphones, and the technologist plays sounds, pure toned, that kind of thing. And they do this at different frequencies, so that's different pitches. And they start with a very quiet sound and they gradually increase it and you press a button when you can hear the sound. And they do that across a number of different pitches, medical term for that would be frequencies, so that they can work out how sensitive your hearing is at these different pitches in an objective measured way. So here are some pure tone audiograms, if you're interested. So normal is here. So yeah, sure.
At some point, if you could just address how routine is routine.
Meaning, how often
should we be having the tests done if there's a chance that it would show up later on?
In just generally in patients with mitochondrial problems.
Yes.
Yeah. So I think I don't routinely do an audiogram on every patient that comes through the door, but I do ask questions about hearing. Is there any context in which your hearing is, different to the person next to you? And if the answer is yes to any of those questions, I would fix up one of these pure tone audiograms. Now, the next question is how often should you do that? And I think the questioning should be happening regularly, every year or two, say. In terms of audiograms, if you had an audiogram that was completely normal and you didn't develop symptoms, it wouldn't really need to be repeated, or maybe 5 years, something like that.
So, like, I know we get like for our son or kids, we get like a baseline for the heart, we get a baseline for this. Is it good to get a baseline in for the hearing?
So I don't think it will do any harm. It's a 5-minute test. It doesn't cause any distress. I think it's entirely a reasonable thing to do. And I think particularly in kids, because they don't tell you when they're not hearing properly, and particularly mitochondrial patients, they've got the odds stacked against them. You want to make sure they can hear, because that way they can learn. If you can't hear, you can't learn. And so frequently when we diagnose these kind of issues, we look back and say, if only it had been picked up 5 years previously, they could have had some kind of amplification, which we'll come to, which might have helped them engage better in schooling, which would allow them to function more as independent individuals later in life.
He's 17, that could be the problem too.
Yeah. I've got a 17-year-old. He's here. I brought him. He's upstairs. He's upstairs. Yeah. Okay, good. So this is what it looks like. Normal would be across the top here. If your hearing is impaired, then you come down the graph, and this is someone who has problems with their hearing across all of the different pitches or frequencies. This is a patient with a very severe sensorineural hearing impairment, and the triangles and the circles represent left or right ears. This is a bit different. You can see it's normal more or less here, but when you get to the higher frequencies, the higher pitches, the ear isn't working properly. And we also see that kind of pattern in people with mitochondrial disorders.
Why do those why do those high pitches go away first?
We think it's because they require more energy to detect them.
Okay.
So they're in part of the cochlea that requires more energy. Yeah, you actually see that also with healthy aging. With normal aging, you lose the high frequencies before you lose the low frequencies. Yeah.
Do you notice if there are any particular patterns of the hearing loss? Like I'm thinking my child has KSS, he's got a cookie bite hearing loss.
Yep.
So do you notice, are there specific types of hearing losses or certain pitches or frequencies that are more consistent with each diagnosis?
So just for everyone else, a cookie bite hearing loss is a bit different to this, is where it's completely normal and then there's a big chunk missing and then it goes back normal again and follows along. So you have a hole, if you like, in the middle of the hearing where you lose frequencies. Typically, when you see that, that's sound induced, typically. Okay? So it's interesting to hear that in Kearns-Sayre syndrome that's been described. So the answer to your question is, what we typically see in mitochondrial patients is a more exaggerated high frequency loss compared to normal aging. And then this progresses and gets worse so that it affects all of the frequencies when it's severe. So your story is interesting, not something I've heard of before, but we're learning all the time. So how can we treat this problem? How are we doing for time, by the way? We're doing perfectly for time. So how can we treat the problem? Well, you know the answer to this, of course. One of which is to try some form of hearing aid, which we'll talk about in detail. The second of which is to try and replace the ear with something called a cochlear implant. And then we can talk a bit about the future and some of the things that people are trying to develop that might provide an even better treatment in years to come. So what's a hearing aid? Well, a hearing aid, you can see the picture here, is a battery operated device that basically picks up the sounds out there and amplifies them. So it increases the volume of the sound and channels that sound into your ear through a little tube that goes through the external auditory canal, which I described, and tries to activate the eardrum in a more effective way. That's what a hearing aid is. There are different bits to it. You've obviously got to have a microphone which senses the sound. You've got to amplify it. You've got to convert that into louder sounds so that you can hear that with the hearing impairment. You've got to have a power source, battery. And some hearing aids also have special shapes to them that direct the sound in the right direction. These have been around for many decades, of course, and are gradually getting better and better in time. So there are three basic types. There are conventional ones that basically picks up all sound, amplifies all sound, and gives that louder sound to the eardrum to try and help improve the hearing. That's really simple. They've been around for 50 years. There are special programmable ones which allow us to just amplify the bit of sound that's missing. So for example, in your cookie bite case, you just amplify the bit of sound that picked up on the audiogram that's missing. And the advantage of that is you're not making people really sensitive to sound that they are already able to detect. And then there are some digital ones that have been around, I guess, for about a decade, which are considerably more expensive, but they're clever in the sense that they can allow programming to ensure that people can hear better in different sound environments. So if you're in a really quiet, I shouldn't do that, if you're in a really quiet room and there's no other background sound, you need one kind of hearing. But if you're out there in the coffee area and there's all this sound going on around, picking out the voice you want to hear is a really tricky thing. And the conventional old-fashioned forms are no good at that, but the digital ones have some programming that allowed you to adapt in those circumstances. Yes?
They also connect to Bluetooth.
Yeah.
And so you can, the modern one, the most recent ones connect to Bluetooth. So mine's set to program to my cell phone.
Yeah.
And so when you weren't on the microphone, I just pushed my buttons and changed you over to make you louder for me.
Yeah.
And they're more expensive,
Yeah. True
statement, worth every penny.
That's very interesting to hear. My wife would love one of those that does the opposite, which is when I
I can't turn it off.
Hi there. Excuse me. I have very, very, very sensitive ears. When I had my hearing test, the lady said that she's never had anybody wanting to crawl out of their skin before she even got to the 50% volume or something. But I also have hearing loss, so I was kind of just wondering.
Well, I think
related?
interesting. So that might get to the issue as to what these tests are actually measuring. So the pure tone audiogram, which I've described to you, is really just testing your ability to sense a pitch. It's completely false. And when on earth does that happen in the world? It's a very crude, and so you clearly have a very sensitive way of doing that. But there are other bits to hearing which are more complex, which is how you separate out sounds in a difficult environment. For example, what happens when there's an echo? How is it that in a room of 20 people you can pick out that person there, their voice? What that tells you is that hearing is not totally passive. You've got to engage your brain and some complicated thinking in order to connect and localize where in space the sound's coming from and who's making that noise.
If somebody's tapping in the room or some incessant noise, it just drives me bananas.
So there are some kind of speech tests which are more real-world speech tests, and people are actually doing research to try and refine these at the moment, so to try and copy what the real world's like, different to the pure tone audiogram. And my guess is that you're perfect on the pure tone audiogram, but with some of these more sophisticated tests, you're probably not going to perform as well as other people of your age. So it might be a kind of higher level of hearing that is causing you difficulty, rather than in the ear itself, where that mechanism is clearly working perfectly because the pure tone audiogram is okay.
But I'm missing the top sounds, some of the top sounds, and I have 3 different tones of tinnitus.
Yeah. So it gets complicated, doesn't
it?
So many of these tests that are routinely done are incredibly simple because they're easy to do and they're well established. But clearly hearing is much more complex than just whether you can hear a particular tone at a particular frequency. And your story illustrates that perfectly.
Complicated and mitochondrial disease?
Sorry?
Complicated and mitochondrial disease?
Complicated generally.
I've never heard that put together before.
Well, complicated generally, and complicated generally, and there's still a huge amount to learn about this.
Sorry, another one. I have talked to a lot of mitochondrial patients of all types of genetic, mutations, and they typically have this left-sided numbness, tingling symptoms that come on with episodic incidences of it's either all left-sided or sometimes right-sided. But with that comes the closing down of the left eustachian tube and complete like blockage of sound from that side. Is that a neurological? Is that a trigeminal nerve issue? I've never heard an explanation as to why.
Yeah, difficult. I mean, my feeling would be it's all part and parcel of a migraine-like episode, and we know people who have migraine generally can get hearing disturbance with that. They can get tinnitus, they can get loss of hearing, and we know that patients with certain kinds of mitochondrial problems are at increased risk of getting migraine, complicated migraine, and the sensation disturbance you're describing down one side of the body with the hearing problem could all be part and parcel of the migraine element, which we think arises from blood vessels in the brain.
So they have ruled out migraines with my case, and instead are looking into seizure, mild seizure activity. Would that also cause a similar neural loss in the ear?
It could possibly. Good. Okay. We're doing fine. So this is what a hearing aid looks like. You know the various components: the microphone, the volume control. Turn it on or off. That's the battery. This is the bit that goes in the ear. Most of these hearing aids are called behind the ear, so the device sits behind the ear itself. But there are more recent developments such as in the ear ones and in the canal, meaning they're in the auditory canal, or completely in the canal. The behind the ear ones you'll be very familiar with. These can be used in all different kinds of hearing problems, and people can have them with mild hearing loss or severe hearing loss at all different ages. The other aids, here's some examples. They're essentially designed to be more cosmetically appealing. You know, with some of them you can't see them. This is in the ear canal. It's a tiny little thing goes inside the ear. You can't see it. Here's one where you can just about see it. These are essentially responses to patients' requests to hide the hearing aids, so it's not obvious that they've got one. And there are several problems which many of you may have come across. In the end, there's some plastic or rubber that's in contact with the skin. It can be irritating. It can cause infections. People sometimes don't like to advertise that they've got hearing problems by having an hearing aid that's visible. And there's this other issue, which is that if you get near electronic systems or in closed spaces, you can get horrible whistling feedback sounds, which can be very irritating. So one longer term solution is to have something called a cochlear implant, and I'll just describe that to you. Essentially what it is it's a sensor that sits on the outside of the scalp, connected to something that's put underneath the skin, shown here, with a wire that goes into the part of the ear that senses sound and activates the auditory nerve. And essentially it's a bypass of the system, so it means that you can pick up sounds, they can be amplified, and a little electrical impulse stimulates the cochlear and auditory nerve, replacing the normal sound system that we have. It requires an operation to be put in, and you can see that in the process inevitably you're going to damage part of the ear itself, so it's not something that we would always do instantly. But I think it's something that some patients with mitochondrial disorders have found to be really helpful. So you typically do this when the hearing problem affects both ears and it's sensorineural, so you now know all about that. We typically do it if conventional hearing aids aren't doing the job, and obviously you need a general anaesthetic for an hour or so to have this procedure done, so people have to be otherwise fit and not, there shouldn't be any risk for them having a general anaesthetic. Other things that people think about are how old people are, how long they've had the deafness, how they communicate, and really, really important is how motivated the patient is, because they've got to kind of relearn how to hear again, because it's not normal hearing, but it's a form of hearing that allows you to communicate, but with a different way. So you've got to be really motivated to learn how to use the cochlear implant. Importantly, these usually are best if people have lost their hearing after they've learned how to speak. The medical term for that is postlingual hearing loss. And the reason why is because if you've learned how to speak, you understand the concept of how speech works. And if you lose your hearing, then people are given a cochlear implant. Those people tend to do much better than people who've never learned how to speak. They just understand how sounds work. Yeah, sure.
Are you aware that any of the CI internal ear hearing aids are waterproof?
So the cochlear implants can be waterproof because they're essentially put under the skin. So people, if you take the thing off the scalp, you can swim with those. Some of the hearing aids.
They have a sachet you can swim with too for the
Do
cochlear
they?
implant.
Yeah. So you can have an adaptation to allow you to go in the water. Yeah.
I was just wondering if you have noticed, I mean, doing this in your profession for however many years, if you've noticed patterns with people's hearing loss in mitochondrial disease, like certain conditions or even in general, do they progressively become worse over the years or anything particular? I don't know.
So I think the answer is generally they do get worse as time goes by. The hearing gets worse slowly. The exception to that are probably patients who had exposure to gentamicin, aminoglycoside, whose hearing went down within days or weeks after they've had the treatment. It probably stays the same. But for most mitochondrial problems, I think it will continue to get worse. Because it does in everybody. We all lose our hearing as we get older, and it's like 2 hits. Yeah.
The other issue is cost. In the US, I've heard as much as $300,000 for a cochlear implant.
Wow. Yeah. Yeah.
And that insurance may cover a small portion of that?
Yeah. I mean, I don't know, because I don't operate in your system.
You
But
had fight insurance. She had a cochlear, it was $50,000 3 years ago. Insurance didn't pay any of it. And she was dead. She completely lost all hearing aid. We had a fight, and finally we ended up, out of the $50,000 we had great insurance, we ended up paying $20,000. So $30,000 out of our pocket.
wow.
And we were very fortunate that we could do it. I mean, I don't know how people who can't.
Yeah. Yeah. So I mean, obviously we don't have that problem in most European countries, and certainly not in England. And we have our challenges. It's not perfect because there's not limitless supply of these things, and I suspect the threshold for putting one of these in patients on this side of the Atlantic is probably lower. In other words, you're more likely to get it, but of course there's a financial constraint attached to that. So we're not living in a perfect world in England, that's for sure. But we don't have these challenges that you all have to face. So, in terms of assessing the hearing before you have a cochlear implant, got it? There's the audiograms and some specialist hearing tests. We also do some special perception tests, which many of you will have experienced. And it's really important that we explain to people before they have the treatment that this is not going to be perfect hearing afterwards. It's going to be better if you're motivated and you learn how to do it, but it's not a cure. It's an improvement, not a cure. There are risks to all surgery, which is why this isn't offered to everyone. You can damage some of the other nerves coming out of the brain. You can get infections. You will lose any natural hearing that you have in that ear because you're damaging the system. And there are other issues such as temporary dizziness, tinnitus, taste disturbance. And one of the twists to it, of course, is because you're putting a metal wire into the ear close to the brain, we have to be very cautious about doing MRI scans of the brain, magnetic resonance scans of the brain after you've had a cochlear implant, because it can dislodge it. The standard position is that if you've had one of these, you shouldn't have an MRI scan on it. You absolutely need to have it because of the dangers of the magnet in the scanner disrupting the cochlear implant. And that's a problem because if you're getting other issues as a mitochondrial patient, we have your neurologists have their arm behind their back because they can't use standard tests. I think I'll skip through this. And just because we're running out of time, the point about these cochlear implants is they've been used for nearly 20 years now. People have been having cochlear implants, and particularly because patients with mitochondrial hearing problems develop it later in life, in their teens or late childhood or adult life, they often do extremely well. And they've been done now, these studies, in perhaps 100 people, 150 people worldwide, maybe more, that we don't know about. And I think the general feeling is it works extremely well in people who have severe bilateral hearing loss affecting both sides. So we're going to have to wrap up soon, so I just thought I'd just touch very briefly on the future. What this shows you is certain work that was been done in San Francisco using stem cells to try and make new hearing components of the ear, and in particular to try and make both the stria vascularis and also these hair cells in a dish. And for the last 5 years there has been some progress in this regard. That it seems technically possible that you could take a cell and turn it into a new ear cell. And the real challenge is going to be how those cells could be used and put into the ears of patients and connect those cells to the nerve cell going into the brain to try and improve hearing. I think it's science fiction at the moment, but I suspect I'm slightly hesitant to say this, but I suspect within 5 to 10 years we'll start to see new trials where patients are given stem cell treatments to treat the hearing, and I would argue that mitochondrial patients might be a great place to start because we understand the problem well, and that you as a group have shown us that things like cochlear implantation can be a real benefit. This is one of the first patients I was involved in who had a cochlear implant, I guess 15 years ago now. Transforms the life, able to talk to kids for the first time with a cochlear implant. And it's important to remember that by picking these things up and giving the right treatment, we can make a big difference to people's lives. And I think I'd better stop, haven't I?